Hi everyone, welcome to workshop 2. My name's Angeline True. For those of you who haven't met me either in the coaching session or in the previous workshop. So today we're going to look at delivering care that matters. So you may recall in workshop 1 we focused on what does matter and how do you measure what matters. So this asks you to consider whether or not you know, whether or not you're delivering what matters, and what processes and mechanisms do you put in place to achieve that. So firstly, I'd like to acknowledge the traditional custodians of the land on which we meet and the many different nations across the regions. We pay our respects to elders past, present and emerging as the holders of the memories, the traditions, the culture and the spiritual well-being of First Nations people. We recognise their continuing connections to land, water, culture and community. We acknowledge any sorry business that may be affecting the communities as a whole, and in the spirit of reconciliation, partnership and mutual respect, we'll continue to work together with the Aboriginal and Torres Strait Islander peoples to shape a health system which better responds to the needs and aspirations of the community. So welcome everyone. There'll be a few people joining us. We've had notification that a few people are running late, but we're just going to do a quick recap. So this is the programme overall. So as I mentioned, what matters in diabetes care, followed by 2 coaching sessions. So we've had some useful light bulb moments in those coaching sessions. So for those of you who haven't yet participated in coaching session, there's still the opportunity to join in. That's where the action learning comes from and the application of the quality improvement approach to help you guide you through that. So then workshop 2, here we are, delivering care that matters. And again, we've got coaching round 3 and 4 following up after this workshop. We then finalise with workshop 3, which is about how do we actually strengthen diabetes care based on all of the learnings we've achieved across the programme. And then we have a final round of 2 coaching sessions. So that's the programme. So what we do is we encourage you to do that self-reflection. So Therese, can I ask you, or Tamika, can I ask you to drop in a knowledge capture sheet, please, into the chat box? Therese, would you mind doing it? It's the same one as before. So that asks you to consider the what. What are your key learnings? What are the key insights? What are the key takeaways from this session? The so what is that reflective practice. What does this mean to me, my patients, my practice, my processes, and my people? And then the now what is, now I've got this insight and understanding, what am I going to do about it? What actions can we take? So before I move on to a quick recap of workshop 1, Paresh, do you want to say a quick hello? I've just noticed that you've joined us there.
Hi everyone.
Oh no, there he is. Sorry, Paresh.
Hi, that's all right. Hi everyone. Thanks, Ange. Apologies, I was a few minutes late. Yeah, great to be here. Great that we're on the second workshop, and really keen to hear how everyone's been getting on. Thank you, Ange.
Okay, thanks, Paresh. I know, workshop 1. As I mentioned, quick recap. We looked at what matters and to whom in diabetes care. We considered how you measure that. You may recall we talked about patient-reported measures, so outcome measures and experience measures. So we considered how to adapt a learning approach to actually drive improvement in care that matters to people living with diabetes. And then we introduced next steps and the coaching activities. So in terms of doing that, that very quickly give you a scroll through of what Paresh does in his practice. Do you want to just give a quick overview, Paresh? Because this pulled together everything that we talked about basically in the last session.
Yeah, great. Thanks, Ange. So one of the things, I guess, we're on the same journey as a lot of people here. You know, we're trying to sort of think about quality improvement and chronic diseases, and you know, we're particularly looking at diabetes as well. So where we've started really in the practice is to think about how we might approach this and how we're going to think about it. So we really started with taking a step back and saying, look, what does a standard approach to looking after people with long-term conditions look like? And we kind of felt first thing is we've got to know our patients, you know, who's got similar need or a like need. So that's having a register of people. It's knowing for that group of people, that cohort of people, what matters to them. And then it's about having a bundle of care that's right to deliver for them. And so it's really identifying that bundle of care and then really having a reliable, robust process to deliver that care and then monitoring and tracking to make sure we're doing it. So that's kind of the broad approach we've started with. We've looked at various models and looking at sort of utilizing the chronic care model is the one we picked. It talks very much about a partnership approach. And then we started to think about, okay, well, if that's our broad approach to looking at people with a chronic condition, what are the specific things we need to do in diabetes? And so we then pulled the diabetes guidelines, both from the College of GPs and the ones we use in Australia, but also some of the national ones, particularly international ones, particularly around the use of some of the newer drugs and cardiac protective effects, and also looks around to see what do we know about what matters to people and sort of identified a bit of a framework. And so we've kind of put all that together. We've got a SharePoint page in the practice around this. So we've put it all together and we're now in that stage of thinking about, well, we've started to implement that. So that's the kind of approach we're looking at in our practice. And you can see on there on the right hand side, there's things like sick day management plans and hypoglycemic plans and things. So we want to try and capture all that information as part of the care planning. And then we've got patient reported measures as well. So we've created some forms to, you know, measure the distress people feel in looking after their diabetes, but also their well-being and their mental health, as well as all the other usual things we would check in diabetes, like HbA1c levels and blood pressure and lipids and so on. So some really specific clinical issues, which we all know about, but also thinking about some things that are more specific to patients around physical and emotional well-being.
So quick
Thanks,
question, Paresh.
Mm-hmm.
Why did you do that?
Really good question. And I guess, you know, maybe some of the thinking around, so I'm going to answer that at three levels, Sanj. So one was really around the fact that we've been doing a bit of quality improvement. So things like, you know, checking the blood pressure in people with diabetes and have they had the influenza vaccination and things. We've been kind of doing that for a while and we kind of felt like that was okay. You know, we were kind of getting there. And when we spoke to the team, the things people were finding hard were perhaps the sort of more complex parts. So people with diabetes who've got complications, comorbidities, and engaging with that sort of group. So rather than thinking about people with diabetes as one group of people, one homogeneous group, we started to think, well, look, actually it's not one homogeneous group. It's a bit more complex than that. There's people with diabetes, but then within that there are people living with diabetes, and it's fairly straightforward. It's the only condition they've got, and they're highly literate. They're the ones that always turn up for their appointments, will always have their blood tests done, etc. Then there's a group of people with diabetes who are, they've got a mixture of conditions. There's some social issues going on, so they're a bit more complex. Sometimes they turn up for appointments, sometimes they don't. They're a bit more of a challenge. And then there's a group where the HbA1cs are really uncontrolled, like the patient who I saw on Monday. The HbA1c's gone up from 12% to 14%. She's got schizophrenia. The mental health condition isn't managed. That's a very different group of people, and we can't use the same system for all of them. It's not one homogeneous group. So it's partly speaking to everyone in the practice and getting a sense of, we can't treat everyone with diabetes in the same way, like one size fits all approach. Maybe we need to think a little bit differently about them, and sort of break them up into subpopulations. So that was kind of the second thing. And I guess a third thing, thinking more broadly and more strategically, and thinking about, look, what's happening in the world of primary care. We've got a whole bunch of reforms going on. We've got My Medicare happening. We're looking at how government's thinking about things in the future, what may or may not happen with care plans. So I guess we want to be, as a practice, on the front foot with some of that. Now, there's a lot of stuff we don't know, but when we look at what government's doing and the way policy is being shaped up, we can probably make an educated guess of the way things are going to go in the direction of travel. So why don't we put ourselves on the front foot and start thinking about that and get a bit of a head start? So that was the third driver.
Fabulous. That's really insightful, Paresh. So there's a question here. I'm asking anyone, if you've got any questions for Paresh, feel free to ask them now. But there's one here from Amanda, who's asking, how do you collect prems, as well as the proms that you use there?
Yeah, really good question, Amanda. So we've been thinking about developing our own. So we've got accreditation coming up in August, and so we pondered quite a lot about, do we develop our own sort of tool for that, and or do we go with one of the standard ones? We landed on going with the standard ones because everyone was feeling a bit too stressed about developing a very specific prem tool. But we have got a specific prem tool we can use. We decided not to use it for accreditation, because there's a process you need to go through to get that approved for accreditation. But we have got a prem tool that we use, or we will be using. It's just that we don't want to survey out patients too much all at the same time. The prem tool we're using is really simple. So it basically looks at the process of care. And Tamika, if you can just put in the link to the Australian experience-based co-design toolkit. There's examples in there that people can look at. But what the experience tool does is it pretty much just maps out a patient journey, and you can customize it. So, for example, patient arrives, patient waits, patient goes into the consultation with the clinician, patient comes out, patient follow-up, as being 5 sort of touch points the patient has. And the experience question we're asking is, at each of these touch points, what words would you use to describe your experience? And there's a list of words that are there, so they can just circle them. And then there's a blank space where they can add some other words as well. So yeah, that's the experience survey tool we've got, and we will be using. We just haven't started using it because of accreditation in August, and so we didn't want to survey our patients too much at this point in time. We want to get the accreditation ones done, and then we'll start using the experience ones later.
Thanks.
Hope that answers your question, Amanda.
Any other questions before we push on? Anything pops to mind, feel free to drop it in the chat box. So in terms of what we did subsequently to the workshop, we had those 2 coaching sessions. And we asked you in the coaching sessions to consider your context. So think about your data, think about what PHN tells you, and think about what problems you encounter in the delivery of diabetes care. We provided a tool there, the problem statement template, to help you define your problem statement. We then took the problem in workshop 2, coaching session 2. We then asked you to consider the problem. So we introduced the concept or the method of root cause analysis. So to try and really unpick what sits behind the problem, what are the drivers of the problem? And then from a QI perspective, where is it potentially better to put your resources, because you're likely to see maximum return by addressing the root cause, distinct from a random change opportunity. So we did that, and then we also discussed in coaching session 2 how to define your aim. So there's an aim statement template, and also we provided an overview of model for improvement. So that's that template there. So for those of you who haven't attended coaching session, there's still opportunity. So with coaching 3 coming up, and if you would like to reach out to your practice development officer, they will be able to help you accelerate through that process. But we're here to talk about delivering care what matters. So what we're going to do is we're going to look at the process of care. First of all, we're going to consider what team-based care is to get us thinking about that. Think about the processes and think about how you can optimise the use of team care arrangements. Now, you may or may not have had the opportunity to look at those questions we posed in advance. We are not expecting the answers to these now, but what we've done is we've framed this session so that we can adopt that adult action learning approach, so that you can understand how you could potentially answer these questions back in your practice. So you hopefully have some light bulb moments as we work our way through. But what I would encourage you to do is, after the session, go away and reflect on the activities and your learnings from today. Go away and consider those key questions, and then think potentially around what improvements you could make in your practice. So team-based care. First one is very quickly, top of head. What do we mean by team? Presh, do you want to introduce this while I just set up the whiteboard? Because Tamika and I will actually capture feedback on the whiteboard. So what do you want to introduce the activity?
Thanks, Ange. Yeah, so I guess really thinking about what does a team mean? You know, we often I think confuse what a team is versus what a group is. And so I think, and did you want to go straight into opening this up, Ange, or?
Yeah, sorry, when
Yeah.
I click on it, it says if I stop presenting, it'll end the presentation for everyone.
Yeah.
Yeah. I didn't want to lose everyone. There, that's fine. And then I'll share this.
So whilst Angie's sharing that, I guess, like, what does a team mean? And and really thinking about it from the, the different lenses. So what does a team mean to you, as in whatever role you have? What does it mean from a patient's perspective? Like when we say a team to a patient, what does that mean for them? And what might it mean for our colleagues? And it'd be worth maybe just capturing some of that onto the whiteboard, as Ange suggests. I think Angie's now sharing the whiteboard. What are people's thoughts?
Feel free to take yourself off mute. Tamika, do you mind dropping any entries in chat in here? And I'll do the voice feedback.
Hi, it's Natalie from the PHN. How you going?
Yeah, good. Hi, Nat.
How are you? My idea of a team from a clinician's point of view is someone who's involved with and communicating throughout a team to provide care to that patient. And from a patient perspective, I would think the team is anyone who they interact with to receive care from a clinician. So the patient may think a team is a lot different because they may only see a couple of people in that team, whereas from a clinician's perspective, it's everyone they invite to help manage that patient.
Fabulous. I'm just going to capture the second point.
Other thoughts?
Working together and including the patient.
Mm-hmm. So that's, I guess, bringing the sort of idea of the patients as a member of the team.
Yeah, bringing them, yeah.
Sorry, what was that third one, Raj?
The patient as a member of the team.
Yeah.
Other thoughts? I guess just maybe, to help maybe people think around it, think also about teams outside of work you might have been involved in. Could be a sporting team, or another sort of team. What does a team mean in that sort of context, and how does that then apply to a diabetes care team or a healthcare team?
Maybe like a support system as such.
What were you thinking there, Bernie?
I just like, when you have people like allied health and everyone, that you can all support each other, if that makes sense, especially if it's a difficult or complex case.
Yeah.
Just to have that person to bounce off.
Uh-huh.
What about family and friends? From a patient's point of view.
Sorry, say that again, Therese. I didn't capture.
Like family and friends, when patients bring other family members or friends into the consultation.
Okay.
Right, it's Natalie again. Would it be considered working to a common goal?
Mm-hmm.
What about things like communicating as a team? as in like, so, you know, so everyone's on the same page, like one
Yeah.
person doesn't say one thing and one is telling them something else.
Yep. So everyone working to the same sort of goals, communicating
Yeah.
around the goals.
Because you know what it's like if you go see a few people and everyone tells you something different as a patient.
Yeah.
Yeah, then it becomes quite confusing.
Yeah.
A couple of ideas in the chat as well, Paresh.
Oh, great. Thank you.
What about celebrating and sharing and celebrating successes?
Yep. So something around celebrating. Yeah. And then in the chat, we've got, yeah. So making sure everyone's on the same page, give information, give or repeat the same info to be consistent and knowing what everyone else is doing so that we're not confusing the person, and then coordinated and organized group of clinicians working together to improve health outcomes of the person.
I think Wendy, you got any feedback, Wendy?
I'd perhaps add using, I guess, a range of skills, knowledge and experience to help achieve mutual goals or outcomes.
Mhm.
Because everyone has something to offer and it's working together towards what you want to help somebody with.
Yeah. So sometimes teams, I guess, are about different people within the team can do the same job or same task to the same level of quality, and so sometimes just around effectiveness and efficiency of who does that. But sometimes different members have very different roles, and you can't deliver that care without having that breadth of roles and functions. Is that what you were thinking, Wendy?
Yes, and also how by having different members of a team, sometimes some members, say, might have a different rapport or relationship with the patient or other staff and be able to help the overall team or other members of the team achieve what they would like to achieve. I'm not being very clear with that, but for example, sometimes the doctor will ask me to do things with the patient or get follow-up things because I have the different relationship with the patient. And I might have the time to coordinate, but it's still part of the team. It's just like I'm a bit of a conduit for doing something.
Yeah. Great, thanks, Wendy. Other thoughts? So for me, looking at that, Ange, there's some common things that start to come out. I think the first and foremost is this whole idea of having some shared goals, a shared purpose, as a sort of important principle. The second thing I think that comes out for me, maybe not 100%, but there's something around roles and responsibilities of different team members. I think a third thing that comes out is the importance of communication between different members of the team, that sort of effective communication. I think is a third thing that comes out for me. There's probably a couple of other things which are mutual respect. Thanks, Donna. So I guess building on that sort of theme of mutual respect, I kind of just reflect. So this is the so what bit, when I'm kind of reflecting on the teams I work in, I'm thinking of a couple of things that particularly happened yesterday, this week, so Monday and yesterday. And yesterday we had a really complex patient who ended up having to refer to the crisis team with mental health issues because we're worried about the harm. And there's sort of three of us involved in that, social worker, nurse practitioner, myself. And when I was thinking about it this morning because I was like looking to see what happened. And trust, I think, was a really fundamental part of it. So, our social worker rang me. I was somewhere else. I had a conversation with her. She spoke to the nurse practitioner. Nurse practitioner liaised back with her, and I guess there was like a just almost unsaid implicit trust between all of us to know that what we were doing for that patient was going to get done by the different members of the team. So I think that mutual respect and trust and appreciation kind of all go hand in hand. And then I guess the final thing I think about is, why is that trust there? Like, how is it that we've got to the position that that trust was there, is there? And then it kind of, it's about not only working as a care team, which is what we were doing for this patient yesterday, for example. It's not only working as a care team, but it's also working on the care team. So it's really looking at and working on how we work as a team, and sort of regularly exploring that. So that's, I think, the fifth thing about a effective team. Whereas if we were just a group of people working for the same practice or under the same roof, I don't think we would have those common themes that have come out. We're just a bunch of people co-located. But we're more than that because of those common themes. And even when I think about people who aren't under the same roof, but where we've got those common themes, we still work as part of a team. So I'm kind of thinking about, we work really closely with palliative care team, for example, and a lot of community sort of care organizations, because we look after a lot of housebound people, and we actually all seem to have the common themes. And I would say we still work quite well as a team with them as well. So you don't always have to be under the same roof to work as a good team. Is that helpful, Ange?
Absolutely correct. So yes, absolutely. Anyone want to add anything when I switch screen and maybe to make a capture it?
Angela, it's Donna here. I think, it's just really developing that theme more. And I think, as Fresh said, you could be co-located, you could be very distant and operate in a virtual environment. I think that comes, like to any team, that there is shared values. And it comes back to the common goal, the best intent. But as clinician, it's an inherent, the respect evolves, other things evolve if you do share those values. And as a team, you signed on to those values, and you may not articulate what those values are, but often in the actions or the way that you conduct yourself, is reflective of those values too, that everyone sort of appreciates, signs on to, respects, trusts, you know.
Yeah. Does anyone actually measure how effective their teams are? I know Paresh talked about the effect, like reviewing on the effectiveness of the team. And I know you mentioned there, Donna, the importance of shared value and working towards those shared goals. Does anyone ever stop and ask the question, how well are we doing as a team? How do we know how well we're doing as a team? I think that's what you were getting to in that last point, Paresh. Is that correct?
Yeah.
Yeah. And I think people, I think sometimes this is done in different ways, right? So I think sometimes it's done as a formal sort of process where, we might look at a survey or something like that and really formally look at it. And sometimes I think it's done informally as well. So maybe in team meetings, just, a sort of softer way of doing it in a conversation on how's it going, how we're working, has anyone got any concerns, that sort of conversation. And then I think, after particular events or issues arise, almost that debriefing process can help as well in terms of making teamwork better, but also working on the team. So, for example, this afternoon we're going to have a little bit of a debrief from this person, case I mentioned yesterday around the person we ended up having to call the crisis intervention team into. And the debrief from that will be very much, how's everyone feeling, what worked well there, what didn't work well, did the advice I gave you, social worker, to our social worker, was that useful advice? What could I have done differently? So that's sort of self-inquiry, but self-inquiry as a team as well. So again, it's a fairly soft way of doing it and relatively informal. But having a sort of dialogic process around where we might do that, and it doesn't need to take long. It'll only take 15 minutes, but just that sort of 15-minute huddle over a cuppa, just having that humble inquiry of what worked well, what didn't work well, what could we do differently in similar situations in the future, I think helps that fifth part.
And also reinforces that mutual respect and trust.
Yeah.
So, yeah, the reciprocity. How do we work well together? How do we support each other? Now I'm moving to our next activity. So rather than jump between slides to show you one slide, I've just moved on the whiteboard. So that activity was a reflection on what do we mean by team, and basically what are the key principles of an effective team. So there's research to back that up. So what we'll do is, once we provide the slides, we'll give you that high-level overview in terms of what the research states there. But it's fundamentally all of those things you identified that we discussed there. So that was objective 1, to think about what do we mean by an effective team. Objective 2 from today was to think about how do we work together? Who does the work? Where's the work done? When's it done? Who else could do it? So, and how's it paid for? So at this point, I just want to do a numbers count. I just want to check in with Katie and Therese to see how many practice staff we've got online, and if we will break up into breakout rooms at this point. Katie, Therese?
Thanks, Ange. We've got So there's a total of 18 people, and if you take out staff, that probably takes it down to 14, maybe 13.
I think we've got 9 from general practice LHD, Katie, and then the rest are between PHN and Prestantia.
So 9 from, right, Presh, I'm going to take your guidance. Do we do this in plenary or do we do it as 2 breakout rooms?
I think let's do it in plenary, Ange.
Yeah. Any other. So this is from general practice staff. What we want to do is just, we've got a big white space here where we're going to do a process map. So we're going to think about the pre-work, the consult work, and then also the post-work. I'll minimize this. So what we want to do is in terms of the activities or the tasks, we're going to distinguish who typically does it. So doctors are coloured pink, nurses yellow, Aboriginal health workers or practitioners green, reception manager admin blue, and any others are called out in white. So we'll work this through together and we'll build up that picture. And then in the process, so maybe we'll do that, and it's only to get a feel for how we do it. I suspect we won't get the full map done, but we'll get a feel. And then what we'll do is Paresh will lead a reflection on what you've produced and challenge you to think in terms of are the right people doing the right things? Could someone else be doing it? Things like that. So remember, this is for people with diabetes. Paresh, do you want to add anything before we open it up?
No, that's great, Ange. Thank you.
Radio then, who wants to make a start and where do you want to make a start? Again, Tamika and I will capture and drop them on the process map. Anyone want to do a shout out? Wendy.
I'm just checking. So, for example, with pre-work, do you mean like the AHP might do the HbA1c or a 715, and the nurse might start the GPMP, and they might do between them do basic odds? Is that the sort of thing you're asking?
Yeah, do you want to take it down a level?
Sorry, what do you
So
mean?
what was that one you called out? The so the HW or P might do what? They might take
HbA1c, ACR, weight, height, blood pressure.
so that would be the Aboriginal health worker may do that. Yeah.
Yes.
And then you mentioned the nurse.
Sometimes the nurse here might do that as well, but between them they start off the 715 or GPMP.
Fresh, do you want to interject?
Yeah, I think about specific tasks. So what I suggest is, I think the 715 absolutely, but let's just maybe think about 3 levels The 3 levels I'm kind of thinking about is what are the tasks that might need to be done. The second level then is who might do those tasks. And then the third level might be, okay, how do we get paid for those tasks? So, you know, the 715, I guess, is a mechanism of payment for a particular task. That the task is about a comprehensive health assessment for a person that identifies as Aboriginal and Torres Strait Islander.
What about
So-
pathology and stuff?
Yeah, blood tests. Sorry, I'm a bit thick today about what you're asking.
I think what we want to do is, like, if you know, when we're providing care to people with diabetes, what are the tasks that need to be done? So we need to make sure, for example, they have their routine pathology done. Yeah. So that routine pathology will be blood tests and a urine screen. We need to make sure that they have their eye checks done. The eye, so, you know, there's 2 parts there, isn't there? Like, we need to make sure that they know they need to have their eye checks done, and then someone's got to do the eye check. So there's kind of 2 tasks there, really. You know, we need to, what else? We need to make sure they have their foot check done. And then someone's got to do the foot check. So things like that. So, you know, if we were providing, like, if we're going to provide good care for people with diabetes, what are the tasks, if all done together, will lead to that good care? So some of that cycle of care stuff, some of it may be more than what's in the cycle of care.
And the process you adopt in the practice to ensure that cycle of care is done, and anything else.
What about regular checking of your blood sugar levels?
Is that here your routine blood test, bloods and urine? Is that
Yeah, I
that,
suppose,
or is
yeah.
that something different? Yeah. So how do you do that? Can I take a step back a bit? So in terms of pre-work, is the pre-work in terms of booking the patient, that one activity, or invite the patient to an appointment?
Yeah. You'd have your 3-point identifier and all of that checks done by your administration or your whoever's doing the booking.
Yeah. And then in terms of so in terms of the pre-work, are you going to ask them to undertake those routine blood tests when they come in? You've got those results to hand. Is that pre-work?
I guess you do a basic set of OBS as well, including the, BGL.
You do that in consult, would it be in consult? And who would do that, Bernie?
I'm guessing a nurse or the Aboriginal health worker practitioner.
Yep.
There you go then. So think about your workflows in the practice. The nurse or the Aboriginal health worker would do that. Say that. Right down.
And Jen Richmond's put in there, we have an annual cycle of care. We can have a consult with the GP care plan, CCA done, referred onto diabetes educator. From there, we might have a list of tasks we want to complete for the annual cycle of care. But they may be depressed, not getting out of bed or showering, limited self-care. So chuck your list away for today and just sit and listen to their concerns, making sure they are safe, not suicidal, etc. Updating GP for follow-up ASAP. That is still part of their annual cycle of care as we are checking self-management and emotional health.
There was a lot there, so I'm going
Yep.
to do an abridged version.
Can you see the chat?
No. What's next? First of all, let me check that. I know that's an abridged version of what was in there. Does that cover it as an abridged version of what was in the note?
Yeah, it's just like saying that you could have all of these plans put in place to carry out, but the patient might come in with an emotional part
Yeah.
which will sidetrack. Getting a history from the family, history from the patient. And then another comment was find out what they, as in the patient, need first. It's their consult. Let them lead it.
And where would you do that? Where would that sit in the workflow?
Your nurse, your Aboriginal health worker with your pre-work. Generate in every consult.
Yeah.
You might also be able to clarify, Ange, at the point when you make the appointment, what people are hoping to talk about in that appointment.
Yeah. What's next?
There's something in the text around diabetes gets integrated in chronic disease management cycles, 3 to 4 monthly review.
Where would that fit, Paresh?
It was in the chat.
Where does it fit in the process?
Oh, probably around. I guess it's probably around that post work. I think, isn't it, to sort of follow up and.
How would you word that? Is that?
Yeah, I think.
And who does it?
Everyone.
Is there a designated person?
If it comes from the GP, it's more, the patient will probably listen more. Or potentially the nurse, than just allocating it to reception.
Has anyone mapped out their process for diabetes patients? Just while I'm fixing this up.
Consult referrals as needed.
So where does that one fit and who does that?
Signed off by your GP, but your nurse or Aboriginal health worker would potentially do the referrals up. Someone just had their hand up. Wendy.
Yeah, that was, yes, that was me saying about in the consult referrals as needed.
Sorry, Wendy, say that again, sorry.
And usually it's done by their GPs here, but I guess practice is different in what they do.
I think sometimes this can all be quite simplistic. It depends on the practice, what facilities they've got in. The fellow from Narromine said they're really well set up, whereas we might not be as set up with resources. Any of these things, they're not designated to just, a lot of these, the lines are blurred. So doing a blood pressure and things like that, if the Aboriginal health workers, you know, trained to do that, they can do a blood pressure. The nurse could do it, the doctor can do it. The admin, if they're trained doing other health things and maybe that practice is going, okay, when you come in, this person, you know, there might be an admin person will do your blood pressure and your height and weight before you go in. So it just depends on who it's designated to in that practice. I think a lot of these things we're very much making these task-based. If I'm seeing a patient and they haven't had a blood pressure done for a while, I'll do one. If they saw the GP yesterday and had a blood pressure and it was okay, I won't do a blood pressure. So it's not, it depends on what the person's had, what they need at the time. I think sometimes this makes it, oh no, well, that's not my job, that's the doctor's job, or no, that's the dietitian's job. You know, any of us can refer. It's not just a nurse that refers or a doctor. I can refer to the dietitian. I can send a note to the endocrinologist if I know that they see someone. So I think like all these sticky labels are great, but they blur between each other's. It's not just one size fits all. And the consult needs to be led by what the patient needs at the time. Get them back again if, you know, look, I'm sorry, we ran out of time today. You know, I'd really like to talk to you about foot checks. Can I get you to come back, you know, maybe in a couple of weeks and we'll go over a few more things. In the meantime, write down any questions you've got and we'll go over those things at the time as well. We have to sort of, like, it took me a long time to get out of task-based nursing because that's what we were trained as, and it's not helpful a lot of the time. We're so concerned about ticking boxes and paperwork. We need to look back at the person, and I understand what all this process is, but it's a fluid process. We're all working for the same thing. So the Aboriginal health worker might do a blood pressure and then they're seeing the GP tomorrow. So the GP, if it was fine, they don't need to do it. So that's my thoughts.
Thank you, Jennifer. Paresh, responses to Jennifer's points.
Yeah, thanks, Jennifer. I think you make a really valid point, which is like teamwork is more than the task, isn't it? And one of the things we often talk about is teaming. So there's a balancing act here, right? So I think what you say is absolutely right. I think the challenge, though, is also at the same time, if you're not clear about the roles and responsibilities, sometimes nothing gets done. So if we, for example, look at and Therese, you may have local data around this. So cycle of care items being done in general practice. Do you have a sense of what the aggregated percentage is? So percentage of people living with diabetes who had all the cycle of care items done in the last 12 months.
I could pull that data. I don't know it off, but yeah, I could pull it before the end of this session if you like.
Okay, that'd be great. So I think there's a balancing act here around having a process and knowing who within that process does what roles and tasks versus what I think was it Jennifer? Sorry, I think it was Jennifer, wasn't it? Versus what Jennifer was talking about. And it's really interesting, Jennifer, because you kind of hit a bit of a hobby horse of mine. So increasingly, one of the, so I hesitated at the beginning when I asked you to think about a sporting team, for example, around teamwork, because whilst historically that's always been good to sort of think about, it also means it's a very static team. Where role all those 5 elements we talked about: shared purpose, roles and responsibilities, communication, trust, and then working on a team, kind of can happen if you've got a static team. Increasingly, what we're finding in general practice, I think, and lots of other organizations, is that the team's not static; it varies. So I been thinking about this in our own practice quite a lot. We have lots of part-time people, so on a Monday the team might be different to the team on a Tuesday to a team on a Wednesday, and so there's this concept called teaming, which is teamwork on the fly. And I think what, Jennifer, you were describing was a little bit of what leans closer towards the idea of teaming, as opposed to that of a static team. So thank you. I just want to acknowledge and thank you, Jennifer, for raising that, because I think it's a really important part of the conversation. And what I'd like to do is come back to it a bit later again. But if you can bear with us, Jennifer, because I think there's a bit of a journey we need to go on in terms of thinking about this and looking at this.
Yep. I'm mindful of the fact we've got 25 minutes left and another potential activity to do. So, Paresh, do you want to take the lead in relation to this?
Mm-hmm. So I might, can you give me 30 seconds, Ange? I'm going to see if I can load something onto the whiteboard you got open. Give me, just bear with me for 30 seconds.
There's also a comment here he's got a question from Tim. There's a question from Tim in the chat. Just around if there is a MBS item number for annual diabetes cycle of care.
Yeah, not anymore. There used to be, but there isn't anymore, unless someone else knows anything different. But yeah, they used to be, but there isn't anymore. I guess I just want to share with people some of what we've been talking about to really help us think about why doing this may or thinking about the task may be helpful. And hopefully we'll come back, in doing so, we'll come back to Jennifer's comment around who does this. You know, so bear with me. Okay, just give me.
What are you loading, Paresh? Maybe
10
in the slide deck.
10 more seconds. So Angie, if you scroll down to the whiteboard at the bottom, there we go. So if you can go to that greeny colored map and zoom in on that.
Yeah, we got this on the slides.
Yeah. So what we're doing here is walking the talk, and we're doing teamwork on the fly. So this is kind of our practice and a bit of a journey we've been on in terms of thinking about how we get different bits of work done by whom. So this is our care planning process, and you can see it's kind of work in progress. But we kind of thought about it in terms of pre-visit, on the day, and post-visit, right? So we've kind of talked about identification is important. We need to confirm eligibility. So those task bits, the problem we were noticing, and this perhaps comes back to a little bit of what I was saying earlier in response to Jennifer, your comment. The problem we were noticing is unless we had a clear role and responsibility of who was going to do that in the practice, we were finding it wasn't happening in a structured or systematic way. So what we did was identified whose role and responsibility that is in the practice. So that's kind of the green colored dots. And you'll see on some of the boxes, there's one green colored dot, and other boxes, there's 3 green colored dots. So that speaks to your comment, Jennifer, that when there's 3 colored green dots, any member of the team can do it. If there's just one green colored dot, that's a specific member of the team that's got that task allocated to them, and the expectation is that team member does it.
So the way you've labelled these here is GP, nurse practitioner, practice nurse, and then the third one is, can't read that one, Paresh.
It's the patient advocates in our practice. Yeah, we have patient advocates. Yeah. So you can see, and I won't go through the details, but you can see what we've tried to do is say pre-visit, on the day, post-visit. There's certain things that need to happen, and those certain things we've identified roles and responsibilities for. And then the yellow post-its kind of talk about some more specifics around that. But you'll see some of those tasks are about having a huddle. And the reason we've got the huddle built in there is to do exactly what you've said, Jennifer, which is to say, look, there's this patient, they need a care plan. These are the bits that they've had done. These are the bits that are missing. And the huddle works out who's going to do what. And so it may look very different for one patient compared to another patient. So it's really trying to describe how the work gets done, but within that, build in that ability to have that flexibility and agility to really make it patient-centered. If you go to the left, Ange, to the very left, let's still go further. Okay, so this is a similar sort of process map. Now, we did this with a bunch of practices we were working with, and said, look, how does care planning get done in your practice at the moment? And you can see in here, it's a slightly different one. So you've got the different roles. You've got the GP, a row for the GP, a row for the practice nurse, receptionist, practice manager, and patient. And it kind of, again, shows how the work gets done. And again, I'm not going to go through it in detail. Happy to share these with you afterwards if you find them useful. But if you just zoom out a little bit, Ange, okay, what you see is in these groups of practices we did the work with, I draw your attention to the GP and the practice nurse and the number of boxes that are in those rows around the work getting done. We then got them to rethink and reimagine how the work might get done. And so if we scroll to the right, this is what it might look like. Now look at the GP and the practice nurse box and how that's changed. And the main reason it's changed is a lot of that work's shifted into a new row at the bottom, which is called a medical practice assistant in this example. And what you got is a column about a third of the way along called the huddle, which is where everyone's involved. So again, this speaks to Jennifer's point around having the flexibility and agility to make teamwork happen. I might just stop there, Ange, because I am cognizant of time, and see if anyone's got any comments or questions around that. And thanks, Therese, for posting that data on the diabetes SIP items recorded in the care cycle. Just out of interest, Therese, do you know how many total patients with diabetes that relates to? Just so we can get a sense of the percentage. It must be at least 21,804, but likely to be more than that. But whilst Teresa's perhaps coming back to us with that.
23,373.
Yeah. So it's kind of interesting, isn't it, that we look at that and there's all sorts of reasons for this. So it's not about making any judgments, but it's about the inquiry of, okay, so what's happening? So out of those 23,000 people, the foot examination is 618 or 835. That's not to say it's not getting done. It may be getting done, but it's not recorded. So whose responsibility is it to record that? The HbA1c, 16,889. So that's what, two-thirds of our total population having that done. Again, not about making a judgment call, but saying that, you know, we don't really know where we are in terms of the care of these people because we haven't got the recording of the data. It could be all 23,000 are having that. We just haven't recorded it, or it may be that 8,000 aren't. Whose role and responsibility is it to make sure that we've got the HbA1cs recorded there? And so that's where the process map can be helpful, together with that huddle process, which allows it to have some flexibility and agility. Kind of sense, I know we're not together, but it almost feels like we've got this kind of quietness, and I'm kind of feeling that might be a reflective moment. But please pop any questions in you have into the chat.
Paresh, a quick question. You talked about HbA1c, you talked about checking whether or not someone's had their foot check. You've talked about, so thinking about earlier, the bloods, the urine, where they are in the cycle of care, so forth. Is that what sits on this task list here on this process map, potentially for people with diabetes?
Sorry, Ange, you want to just reframe that question? I'm not sure I caught what you were asking. So
we've talked more granularly in terms of you
Yeah.
get your HB1AC, you get your urine test
Yeah.
done, you get this, you get that, you get the other done.
Yeah.
Is that what sits behind this task list?
Yeah, so what sits behind that task list? Well, it's a step before, right? So it's that GPRN huddle is to say, so the way this would get acted out in the practice is we've got a patient that's been identified for a care plan. The nurses confirm their eligibility for a care plan. I'd have a huddle with the nurse and we'd say, okay, the nurse would say, Paresh, you've got these 3 people due for a care plan next week. And we'd literally go through patient by patient very quickly. So the process only takes 10, 15 minutes. There's a bit of groundwork done beforehand. And it would be, they haven't had an HbA1c done. We haven't got a foot check recorded. The last, blood pressure check was 9 months ago. And I might say, oh yeah, but they saw the endocrinologist 2 months ago. Let's just look in the letter and see whether we've got that there. So that GPRN huddle, it's a very quick way of going through a bit of a checklist of that person's chronic condition and saying what are the care gaps, if any. And sometimes it's just documentation related, but sometimes there are care gaps. Out of that GPRN huddle comes a task list. It might be, they haven't had pathology. Look, let's ask them to have the pathology done before they come in to see us. So the task list is a list of activity that needs to be done in order to address the care gap. It might be chasing up the previous specialist letter. It might be chasing up the previous allied health letter if that's not there. So it's allowing that communication between the GP and RN, recognizing we said communication's an important part of all of this. It's actually building in time for that communication to happen, to then generate a series of tasks around who does that. And you'll see the nurse has a huddle with the PA as well. That's again to get this administrative support for the nurse to get some of that work perhaps action by the patient advocate. So yeah.
Yeah, I do. So Jennifer, I know you challenged the task-based approach and introduced the concept of being more adaptive in general practice, recognising the dynamics of working on a team. Does this help to some extent resolve that challenge? I'd be interested in your feedback.
Not really. I don't find, I think I've been doing this for a number of years. I've got the communication with the people that, if I know they're in integrated care, I will send a report to integrated care so they're up to date on what things are done. Medical software, any data collection you have depends on how the data is entered. We've got medical directors, so foot checks and eye checks have to be put in manually. Otherwise, if I did a PenCat search, it shows that none of our patients have had a foot check. So you can't just look on those stats and go, oh, there's not many people have had a foot check. We need to task that bit a bit better. You just got to ask the patient when they come in. Now talking about the annual cycle of care, they recommend having a foot check done once a year. The doctor, the RN, or, the diabetes educator, the Aboriginal health worker, the podiatrist, any of those people can do it. But it's really good if you can remember to get it done once a year. Maybe, near your birthday, you remember you need to have your foot check done. Go to the optometrist, so it's a bit easier to remember. If you've been to the optometrist, let your GP know or let your nurse know, and we can, pop it in. But we've got to go manually into another system to put those details in. Pathology, blood pressure, all those things will go on. And with medical director there, the diabetes register, if one thing, you know, their HbA1c is out by one day, the whole line is red. So it doesn't tell me anything. That whole page is red, which is depressing. You know, all our software needs to be better updated so that when you're doing something, you can click a little form, like when you're doing your examination, you put the blood pressure, the blood glucose in, all of that will go across into that diabetes register. But the foot check, you've got to go through some 16-page click thing, which I've spoken to Therese about. So they're the bits that frustrate me. But the rest of this, I don't know.
So I'm going to challenge you now. What if you left, or what if you got someone new, like a new nurse, newly qualified, didn't understand your processes, didn't understand the cycle of care? Would they have something to follow? Would they know what to do, when to do it, how to do it, where to do it?
Well, I would hope that I would be able to orientate them, unless I drop dead, and then they would have to rely on the policy and procedure that I've written. So I've written everything. We didn't have much policy and procedure, so I've written like over 20. I dodged that bullet for a long time, but last few years I've written about 20 policy and procedure. So I've written the policy and the procedure so that if I drop dead, they can walk over my corpse, the next person can come in.
I didn't mean that.
I know, no, but I'm just saying, if we've got our system set up, and I've tried to set my system up so that if I left, or if I became unwell or retired or something, one, I would first orientate that person. Like, we get new registrars in, I chat to them about the diabetes clinic, how you refer, what the annual cycle of care is, that we work together. So, like, I think a lot of this, I don't know if this is sort of aimed more for people that haven't worked in this and are trying to understand what the system is. Like, you know, if you wanted to know how to do the annual cycle of care, you look up on my policy and procedure book, you know, folder, and it's got what you do. Invite them in, introduce yourself, ask them how they are, you know, get all their details, check their allergies, you know, smoking, alcohol, all those sorts of things. You know, ask them, so what's brought you to see me today? Like, that's my thought. So, like, you know, I would assume that I have systems set up. Same thing, I've just found out I did get the 1 day a week job at the hospital. And there's the community nurse who's wanting to do her diabetes course. So I am going to help her through it and train her up, so that then hopefully we can get a diabetes educator role happening at the hospital. Still waiting to hear back from the government for my letters, I've written them, because I think that role's important. So then I would be handing over all those things. I wouldn't say, okay, here's the job, I've got this role for you now, go for it. I would go through with that, which is part of handing on, which is what we should all be doing.
Yes. So Paresh, I'm coming back to you now. So what has been the feedback and the benefit of you adopting this approach in your practice?
I think
well, first of all, rationale, feedback.
Yeah, I think for us, Ange, it's been there's 2 or 3 benefits of adopting it. One is the process of coming up with this approach was a sort of inclusive approach. So it was, you know, discussed together with the team. People were putting post-its up, etc. In terms of designing the process. So I think that was a positive thing, because it meant people were coming up with it together, working together, and understanding how the work gets done together. So that's been positive. I think the second bit's been positives. That's been positives probably around the question you asked, which is what happens if someone leaves. And what we found is actually having a simple 1-pager flowchart that shows how the work gets done. It's been really useful around orientating new people. You know, we did have the situation when one of our significant patient advocates left last year without a handover because her younger brother suddenly got killed in a road traffic accident, so she just had to leave and go without a handover to anyone. So again, having the process documented in this sort of way where other people are involved in it and it's a visual, again, was really helpful. The third thing is, and I totally understand the limitations of data and
systems,
medical director and filling in boxes and tick boxes and things. But the other thing is what we've been able to do with this sort of process is to start to say, what are some of the metrics we can use? So, you know, the culture, I guess, we're trying to build is to say, in order to provide this care, we need to have a degree of confidence and assurance that we know this is happening, and what are the indicators to tell us these processes are being acted out in the way they should be. And so we've, you know, the third benefits has been being able to put some metrics and indicators around these activities, around these processes.
Thank you, Paresh. Now I'm mindful of time. So we're at time now, so I'm going to jump to next steps for everyone. Right, this is where we just completed the workshop on delivering care that matters and proposed the methodology so you can map the workflow to ensure you're delivering care that matters. And I'm going to leave you with the question, would that be helpful in our practice? Where would we make changes? How do we currently operate? Where's our pain points? Because there may well be pain points in your processes that you might want to work on for improvement. So if you haven't already done so, the coaching sessions are on the 10th and the 11th of April. And in terms of those people who have participated, they're up to the point of defining their goal. And actually, there is the potential now to think through your care processes and also how you utilise MBS team care arrangements. So, in terms of knowledge capture, if you'd like to reflect on today using the knowledge capture sheet, please do so. So any key takeaways? What are the implications of this? What do you think you need to do moving forward? Leave that to you. So any final questions to Paresh or the PHN? Right. So just for GPs who've participated, just to remind you, you can log your CPD. So any feedback, any queries, liaise with Therese or your local practice development person. And at this point, just like to say thank you everyone for your participation and insights. So thanks everyone. See you at the coaching sessions.
Thank you.
Thanks,
you.
Ange. Thanks, Fresh. Thanks,
Bye.
everyone.
Bye.